Our second presenter is Dr. Colin Greengrass. Dr. Colin works as a senior lecturer in pharmacology at Royal College of Surgeons of Ireland, Bahrain Center. After completing his MSc in neuroscience from London and PhD from National University of Singapore, he involved himself in different aspects of teaching, learning, and assessment. He also completed his Master in Health Profession Education. Previously, he has worked in leadership role in medical education in different colleges of Saudi Arabia. Dr. Greengrass has consulted on educational program development projects in several institutions across the Gulf region and has conducted numerous workshops worldwide in the field of medical education, especially pre-conferences workshop held in AMEE in 2018. Dr. Colin is going to talk about the role of cognitive psychology in curriculum design, providing structure to clinical reasoning. Please, Dr. Colin.
Okay, great. He is done.
Thank you very much indeed. Okay, so just switching to presentation mode. Excellent. Yeah, so it's a great honor and a great pleasure to be here to talk to you today. The role of cognitive psychology in curriculum design, providing a structure to clinical reasoning. This will be the topic of this presentation. A little bit about myself. I'm Academic Director for Technology Enhanced Learning, amongst other things, in the Royal College of Surgeons in Ireland, RCSI, Medical University of Bahrain. Surface versus deep learning. Well, it would be expected that deep learning would be employed by our potential medical doctors to a large degree, we would hope. And we would expect that our doctors would have a deep level of understanding of the various conditions in order to accurately diagnose and treat a patient, we would hope. And this short discourse will focus on how a deeper form of learning and potentially more accurate diagnostic reasoning can be brought into medical education through a specific curriculum design ethos. In order to frame this approach, we must first examine how we learn. What we'll be looking at today is how do we learn, store, retrieve, and make sense of information, processes and mechanisms involved in diagnostic reasoning, a curriculum design approach for structuring diagnostic reasoning, and achieving optimal memory encoding, and also constructing and streamlining, which is very important, medical curriculum. So firstly, how do we learn, store, retrieve, and make sense of information? Well, firstly, if we look at schema theory, which is pretty valid theory of learning, knowledge is thought to be held within conceptual schema in the brain. And this is contained within networks of neurons, usually via synaptic connections between them. Schema theory describes how knowledge is structured in memory. And schema or schemata are knowledge structures in the brain, schemata being plural of schema. Schema represent linked components of knowledge which form concepts or ideas. They're constructed during learning, and they are thought to form the structure of long-term memory. We have a couple of schema as examples here. Simple schema, which involves an object, and the various facets and descriptions about what that object is like. And then we have complex schema, where we are looking at the interactions between different objects, each of those objects having a description like that of the simple schema. Well, learning activates and builds additional elements into conceptual schema. And further learning may also form a link between previously unlinked schema without the addition of any further components. So this is constantly going on while we're learning. In fact, in daily life, constantly we are building schema through more and more complicated synaptic connections. Now, the process of acquiring schema occupies a component of working memory during the learning process. And what is working memory? We'll look at that in a moment. Working memory is basically when faced with learning new learning items, working memory tries to sort out what it means by fitting everything together, forming each component's internal structure. So here are some components of something we are looking at right now. We are trying to learn what this means. How do we learn the meaning of these components where we try to establish an internal structure, how everything fits together, how everything is ordered. And that really forms a schema. Now, if there's any prior knowledge, the working memory will access this. And what it will do with that, it will try to understand how new information, which we're facing here, fits in terms of what we already know. This refers to schema in long-term memory, all the things we already know, which may be related to these objects here. And we try to make sense and try to work out how they all fit together. What's the internal structure from what we already know? Now, when a fragment of knowledge is presented which doesn't fit in with any established structure, retention, which is the formation of long-term memory, can fail. And if retention occurs, it's often fragmented and it's not very useful in practice. And as we can see here in this diagram, we have these various blocks forming schema, and these are quite different. These objects to learn are quite different. They really don't fit in with anything else. So we can't rely on long-term memory to really work out the internal structure of these. And even if we did implant this into working memory, it wouldn't be related to anything else. It'd be an isolated fragment. Constructivism and schema. Well, constructivism is closely linked to schema theory in that pre-established schema are augmented by experience to form more complex, more robust schema. So we're constantly refining and expanding upon the schema that we already have when learning. Previously defined schema provide a framework for construction of new schema, and existing schema can influence patterns of incorporation of new information. This last part is very important. What we see here in this example is that cognitive constructivist principles, this particular picture represents two individuals who interpret new knowledge differently in terms of what they already know. Okay, that's constructivism. That's what it's all about. You will interpret something in terms of what you already know, but that may skew the interpretation. And this phenomenon is not ideal for graduates from a medical program. We would hope and expect some degree of uniformity, in fact, a good degree of uniformity in all of the graduates coming from a medical program. The working memory is limited in its capacity. It can only process around 4 plus or minus 1, that's 3 to 5 components at one time within a 30-second block of activity. And this is where cognitive load comes in, and cognitive load theory. Cognitive load theory introduces the idea of load. How much can working memory cope with? What is the capacity of working memory? Cognitive load theory describes how working memory processes information during the process of learning from a load perspective. Intrinsic cognitive overload. Now, if we remember that we can only process 4 plus or minus 1 components at one time, here we have far too many. So there are too many objects which we are trying to learn. We're trying to work out the internal structure of all of these, how they fit together. Within this period of time of around 30 seconds, it's not going to work. We are limited to around 4 plus or minus 1. So when we're faced with too many components, this constitutes intrinsic cognitive overload. The working memory also attempts to link components in order to develop this connecting concept, as we know, and it often uses what is already known, as I just described. But this also occupies a status of load on working memory, and it's called germane cognitive load. When the working memory attempts to link components in order to develop a connecting concept, this exerts that load called germane cognitive load, which refers to the process of accessing, conceptualizing information in this manner. Now, the less complete a structure, or the more incomplete a structure or schema of underlying knowledge, the more cognitive load is required. And here again, we have two examples. In example 2 over here, we have a very much complete schemata. So we have various schema which are all linked together. So this is information about one object, this is information about a related object, and information about another related object. And they're all linked together. We know the linkages. It represents a robust schemata. Example number 1 is a little bit different. There are a lot of incomplete schema here and incomplete interactions. So we don't know everything, or this person doesn't know everything about this particular concept. So example 2 represents long-term memory that has a more complete set of schema, and example 1, a less complete set of schema. Now, germane cognitive load will usually be lower in individual 2 because they have that more complete set of schema. They're able to bypass much of that working out process, and the cognitive load will be less. Now, this is a kind of gross oversimplification of memory. There are numerous other memory access structures, pathways, indexing characteristics, which will influence the amount of cognitive effort required. But the basic principle here is very important. It does have a component of learning, and it is important in curriculum design and in instructional design. So when a component also is presented, which is unrelated to a possible concept, this produces extraneous cognitive load. So here we have these 5 elements, and then we have another one which looks a little bit out of place. Now, if you're faced with learning something and everything seems to fit together, but there's something else that doesn't really fit, you're trying to fit it in to this central unifying concept, but it doesn't work because it's not related. Again, this is very important in curriculum design and instructional design. And it's called extraneous cognitive load. Why is it a load? Well, it's a load in order to try and work out how this fits in firstly, and then when you find it doesn't fit in, you are now ruling this particular object out and starting again with the objects which do fit together. So it occupies a cognitive load called extraneous cognitive load. Looking at the processes and mechanisms involved in diagnostic reasoning, we're trying to achieve a curriculum structure which enables us to optimize diagnostic reasoning. How doctors think when they diagnose a case is called diagnostic reasoning. And when encountering a clinical case, the working memory again attempts to sort and conceptualize the components of that case. Now, the components of the case are compared with what is already known in long-term memory to arrive at an understanding of the case premise, in the very least, or to make a diagnosis. There are 3 main types of diagnostic reasoning: pattern recognition, hypothetico-deductive reasoning, and scheme-inductive reasoning. Now, pattern recognition comes with extensive clinical experience. Eventually, this experience leads to acquisition of a repertoire of problems and their solutions. Pattern recognition uses the resolution of past problems to inform on and address new but similar problems. But pattern recognition, as it comes with extensive clinical experience, is definitely a successful diagnostic reasoning strategy, but it's only really available to experts. It's not available to novices or those on their way to becoming experts. The components of, my apologies, the components of these various cases, this repertoire of cases, are termed illness scripts. And illness scripts are embedded in long-term memory, again, a schema, and we can see a series of cases which they've come across, which are embedded as schema in long-term memory. They form the basis of pattern recognition when facing new cases, the same basic principles again. Utilizing illness scripts, interestingly, is usually a System 1 processing task. Now, System 1 processing is part of a fast, intuitive, and largely unconscious system of decision-making. You don't know why you're making that decision. You just feel intuitive about it. You're not really analyzing each component and how it fits together within that decision-making process. It's largely unconscious. This is a highly efficient, rapid process, but it's only accurate if patterns are correct. Just to give some context, more than type 1 processing is utilized in greater than 95% of our decision-making daily. We're not aware of our decision-making. It's intuitive, yet we are making decisions, and that's System 1 processing. But the accuracy of pattern recognition, well, excessive reliance on pattern recognition has been shown to decrease diagnostic accuracy, and that can be problematic. And some studies have particularly cautioned against its overuse among inadequately experienced clinicians. Looking at the declarative system, that's quite different to System 1. System 2 is analytical. Processing is conscious, declarative, and deliberative. You know that you are working through a problem. You're very conscious of it. It has a high cognitive awareness, and it commonly utilizes deductive and inductive reasoning strategies. One of those is hypothetico-deductive reasoning. Hypothetical deductive reasoning involves the procedure of developing hypotheses and testing them for best fits. You come across a case, you develop hypotheses which describe that case. The physician relates the general knowledge of the disease hypothesized to the specific signs and symptoms of the patient, and those least appropriate or with the least comfortable fit are rejected, and the remaining hypothesis is sought. So it's a kind of trial and error to see whether it fits into this particular case description. Hypothetical deductive reasoning is often superficial, and you can learn hypothetical deductive reasoning by involving rote memorization of small fragmented packets of information or long lists of static diagnoses. The problems with hypothetical deductive reasoning, well, only a limited number of possible cases might be considered at one time. So we come across a case, we consider several different solutions, several different diagnoses, but we can only really, because of the limitations of the working memory, we can only really concentrate on 4 plus or minus 1 different cases at one time. Well, we may need more than that number because those cases might not cover the case we are coming across currently. And the case experience may also have some atypical elements that don't fit into any of the known cases. In this regard, it would be impossible to make a diagnosis. Scheme inductive reasoning. This is perhaps the one we're going to look at. Indeed, it is. In scheme inductive reasoning, structures provide specified pathways for diagnosis, conceptualized as decision trees. Diagnosticians gather information to distinguish between choices and make decisions at branching points in a decision tree. So here we have dysphagia, and we're making decisions based on various symptoms and signs along this tree, eventually arriving at a diagnosis. And this is what we're looking at here, all about dysphagia, is a scheme. Now, a scheme describes a diagnostic process for an initial presentation of dysphagia. After several branching points, the number of diagnostic options has been considerably reduced, and this type of problem solving represents the climbing of a conditional inductive tree. The forms of knowledge that are required and used in scheme inductive reasoning are a lot more sophisticated than in hypothetical deductive reasoning. Clinical findings, anatomical locations, pathophysiologic details, disease taxonomies are all important, and they're used in this form of reasoning. And also higher order knowledge structures where we are linking intricate networks into a scheme of relationships and diagnoses, which is what this is all about. What's the difference between scheme and schema? It's similar terminology. Well, schema are different to schemes in that schema are internalized cognitive networks. So each one of these little colored balls is a schema, and the whole thing linked together, because it's linked together, also forms a schema, but a more detailed one. Schemes are external representations which are represented here in this chart of dysphagia. Schemes may not be identical to schemata, but likely they are close to the actual internal representation if it's been learned properly. So for diagnostic reasoning, what is the best method? Scheme inductive reasoning is shown to be associated with superior diagnostic success than hypothetical deductive reasoning. And this is found in both novices and experts, that it has a superior diagnostic success. Hypothetical deductive reasoning is an inferior diagnostic strategy. Pattern recognition and scheme inductive reasoning are basically similar in their level of diagnostic success, except pattern recognition is really only found with experts, and it comes with experience. But scheme inductive reasoning is valid for all stages of the learning process because it also is valid for novices, where they can develop scheme inductive reasoning. To enhance diagnostic cognition and performance, we need to be able to learn and establish integrated schema in memory comprising knowledge and related skills. I think we've really established that. And we need to be able to integrate knowledge to make scheme inductively based decisions in clinical practice. And the key here, integrate knowledge. Now, the curriculum has a fundamental role in achieving this aim. And we'll look at some examples of how or what could be done to do so. So can we optimize the structure of a curriculum to enhance diagnostic reasoning? Firstly, looking at the theoretical bit. So schemes are considered to reflect an organized structure for diagnostic reasoning, as we have here, but also they can reflect an organized knowledge framework for learning. So it's not just about diagnostic reasoning, but you could actually learn this scheme. It's been argued that teaching or learning schemes such as these is beneficial for improving problem solving and thus diagnostic reasoning. And there's a little bit of evidence to show that, yes, learning these schemes, a few of them, can improve diagnostic reasoning. But is the title. Memorizing schemes does not equate with good learning practice. Schemes are not well encoded for easy learning. It's okay when you have around 10 of them you have to learn. When it becomes hundreds, then it becomes problematic. There's a lot of confusion within those schemes. And memory, long-term memory, doesn't deal with them easily. We have to learn in a different way to try and learn these schemes. So learning them directly doesn't work. Potentially the best method to learn schemes is through a curriculum driven by memory encoding principles, yet adhering to scheme construction. And we'll look at how that might be done. So what are memory encoding principles? Well, effective encoding. So in order to learn and to store a memory, this requires information to be presented or organized in specific ways in order for learning to take place efficiently. Now, memory encoding is categorized as mnemonic and organizational. We'll look at both. Mnemonic is all about imagery and narrative. It's telling visually based stories. The best way of doing it is really through animation and simulation. Computerized simulation is fantastic for it. Mnemonic encoding utilizes mechanisms which facilitate learning, specifically through imaging and narrative. And mental imagery refers to mental representations of visual, spatial knowledge, such as in this diagram here, the physical properties, which we'll look at in a moment, of any objects and event represented. Imagery, however, must also take account of cognitive load and its limitations, and having too many elements and things which are superfluous would detract from this learning experience. And here we have the whole thing as an animation. We have our nucleus, nuclear pores, the ribosome, then we have the endoplasmic reticulum, we have some transport vesicles, Golgi apparatus, secretory vesicles. Then we go on to, there's an lysosome poking out, the cytoskeleton, mitochondria, and peroxisomes. And that's really what we need here. In fact, if we were really dealing with cognitive load, we would not have mitochondria, peroxisomes, and lysosomes, because they're not related to the central concept, which here is all about translation and transport of proteins to the cell surface. And as you can see here, this animation kind of describes, it's not completely accurate because that ribosome would actually be on the endoplasmic reticulum if it was doing this. Organizational encoding. There are several types of organizational encoding. There are those which are involved with categorization, outlining, describing hierarchies, concept mapping, which is very important, chunking, elaboration, and narrative. And these are some examples of how you can describe outlining, chunking, and narrative through a graphic like this, categorization and chunking, and the one which I love to use and it's very useful is concept mapping, which can describe outlining, hierarchies, organization, and narrative. Now, aiding organizational encoding. Organizing information whenever we're teaching or learning anything can allow the bypass of the sorting stage of working memory. So these elements, we don't know its internal structure. Well, we can teach the basics of its internal structure, aid the resolution of its internal structure by the student having access to some method of organizational encoding. And we'll look at how that works in a moment. The solar taxonomy. This is the structure of observed, my apologies, learning outcomes. Okay, taxonomy describes the stages of learning. And this was first proposed by Professor John Biggs. So the Solo taxonomy has many uses in education. Usually the Solo taxonomy is used to formulate learning objectives, to assess depth of learning, most important, to indicate the ability to complete a task, in our case would be diagnostic reasoning, but it also, importantly, represents the structuring of content according to organizational encoding principles. Other importances of the Solo taxonomy is that it focuses on the following: the process of construction of knowledge, the integration of constructed knowledge, the utility of constructed knowledge related to task completion, observable evidence of a student's understanding, and outcomes of knowledge rather than just merely descriptions of knowledge. This is a very useful taxonomy for developing a curriculum. Now, the Solo taxonomy is split into 5 categories or phases. We have the first 3, pre-structural, unistructural, and multistructural, which really constitute a limited, fragmented knowledge structure. What we're really trying to achieve is something in this domain, a relational and extended abstract. So an ideal curriculum would largely dispense with phases 1 to 3. The first 3 levels represent surface learning. They're pre-analytical. They're not very useful in practice. If we're teaching our students lots and lots of this pre-analytical surface learning, then they won't be able to use it in practice, and in this case, within diagnostic reasoning. But the final 2 levels focus on depth of knowledge and depth of understanding. This is relational and extended abstract. Now, an ideal curriculum will try to establish relational aspects from the beginning. But how could this be done? Well, we'll see some ideas. Now, the problem is that we often deliver content in these forms. Unistructural, which refers to a single isolated schema, a single object, not related to anything at all. Multistructural, which are multiple different objects, which are not really related to anything at all. Relational and extended, this is where the relation between different schema occurs. The relational phase. Well, Biggs mentions that in the Solo taxonomy, the relational phase refers to a stage where sufficient knowledge on a subject has been acquired. It's now integrated. If we look at this diagram here of all these schema, they are actually in a relational phase. They're linked together. We know how this object is linked to this, or this structure, or this biological system is linked to this. At a relational level, the learner now starts to see how elements of a subject are put together. And now they can start to make at least a kind of rudimentary diagnosis, maybe without the detail. Okay, I'm hearing myself back a little bit. At the relational level, a learner now has the ability to create structures and systems for sorting new knowledge. At the relational level, a learner can view a topic from several perspectives. And at the relational phase, prepares the learner for problem solving similar to diagnostic reasoning, which is all involving this kind of setup. Also at the relational level, the learner can begin to explain connections between things using systemic and theoretical modeling. Now, this really looks like diagnostic reasoning, at least the beginnings of it. A learner can ask questions such as, what would happen if? What would be the downstream effects of something upstream? What would be the system effects of something affecting one system on another system? Now, this is the level we should aim for in the development of a curriculum. But how can this be done? So now the same question, can we optimize the structure of a curriculum to enhance diagnostic reasoning, the practical part? Well, firstly, we use outlining. We define and provide an overview and a scaffold for learning. And we'll look at some examples of that in a moment. An overview, in this case, we're just going to come up with, is a summary of body systems and how they interact. And what that enables you to do, or learner enables, that enables a learner to do, is to track what happens if there's a system failure downstream, upstream. Subsequently, examining body systems and pathophysiology in more detail. So let's look at what all that means. So firstly, it can all be achieved by outlining, and outlining a process can be achieved through concept mapping. And here we have a process which is outlined through concept mapping. Mutant DNA carried through cell division via meiosis, via mitosis, etc., what can happen downstream. Now, this provides a framework for understanding major interactions between components. And each component firstly will be described at a basic level in order to define how one may impact another. Now, later on, we will describe each component in more detail, more intricate detail. Here's another example of this kind of mapping. We have these three major systems: what happens in a circulatory system at a basic level, what happens in a respiratory system, what happens in the gastrointestinal system, all at a very basic general level. But we look at how one affects another, how perhaps dysfunction of one affects another. Now, this provides a scaffold for understanding interactions between components. It provides a structure for knowledge, despite it being relatively superficial. So we could potentially know the internal structure, at least it may not be absolutely complete, but we know the basic internal structure of a new learning element from the outline that we have been given. Now, this allows context to be drawn in determining the structure of elements in a unit of knowledge and provides a scaffold, what we're seeing here, for incorporation of new knowledge. So basically, we start with this very basic system, and then we look at it in far more detail. The learner must have access to this kind of map, this thing here. It must have access to this kind of map structure at all times, because it provides a means of understanding interactions between different components, a structure for conceptualizing new knowledge, and where subsequently more detailed knowledge will be incorporated into that structure, it gives that overarching structure for that knowledge to be incorporated. The outlining process largely bypasses the first three phases of the solo taxonomy. And this leads to a more relational form of a curriculum. Now, it should improve accuracy of heuristics, and there's some evidence that it does. And it should also scaffold learning more towards rapid generation of accurate, robust algorithms, which there's some evidence that this kind of setup also does. Something which we've all definitely come across in the development of a curricula is the division of normal function followed by abnormal function, normalization of function, and application and practice in respect of clinical practice. And all of these are very much valid and very useful in this kind of curriculum. Yes, this layering definitely needs to take place. But how could we really manage a learning framework with all these maps and this various concept maps all linked together? And it's impossible, isn't it? It would take pages and pages of paper. The students would have to have, well, hundreds and hundreds of pages like they take to revise for exams. Actually, the learning management system could cope with it all. And the learning management system, computerized learning management system, virtual learning environment, can provide an interactive curriculum map. What this does is it describes each component, in this case of the respiratory system. It's computerized, and you click on a particular node and it takes you to somewhere else. So for instance, you click on the node for lung cancer, it takes you to all the information, or another map, which is describing lung cancer. Click on asthma, and it takes you to a map which is describing all the facets of asthma, which we'll look at one in a moment. But it also provides a clear logical structure to the curriculum. It enables the student to view a scaffold. We're seeing, this is how we want the student to see the curriculum and how everything is linked together, and the student can also see that. Takes away a lot of that germane cognitive load which was required in trying to sort out information. And here we have the next step, where we have components for asthma. And we're looking at asthma from properties of gases, diffusion, gases exchange across membranes, all the way up to clinical applications through pharmacology, therapeutics, etc. And all of the linkages between them are made explicit. Interestingly, within a learning management system, all being computerized, we could have, you click on one particular node and it gives you something like this. It gives you a micro-learning resource. It may give you another map which shows you how this is all linked together conceptually. And then that would offer you a micro-learning resource. Now, we've probably established that schemes like this scheme for dysphagia, they're difficult to learn, especially when you have many, many of them. But instead, what we have learned, or what we've done here, is we've potentially learned the scheme by causation through an integrated understanding of basic medical sciences. We've done it according to memory encoding principles, which learning schemes doesn't adhere to. But we could have a monster on our hands. If we're looking at all of the content from all of medicine, all conceptually mapped and linked together, it's a huge curriculum. This could be done. It's valid to try and do this, but it's a huge, monstrously sized curriculum. So what we would need to do is we need to determine the necessary and unnecessary content in the curriculum derived according to relevance to defined common clinical presentations, which the curriculum will focus upon. And here are some examples of those clinical presentations. If there's something in this massive, monstrous curriculum which doesn't refer to these clinical presentations, then we minimize or remove it. We streamline the curriculum. Content load, so the amount of content, rather than just cutting something out, the amount of content. So we may decrease the amount of content in a particular area, which is refined according to the knowledge requirements of these cases as well. And this minimizes also the inclusion of rare diseases and disorders in the curriculum, which are not necessary for general clinical practice in a specific region. So disease states which are very uncommon in a particular region, you won't include them. And the basic sciences or the basic medical sciences which are leading up to an understanding or diagnosis of that condition, which is very rare, will also be removed or minimized if they're not required elsewhere. But this will make the curriculum manageable for the learner and manageable administratively.
Dr. Colin, 5 minutes.
Onto the solar taxonomy a little bit more, the extended abstract phase, which we didn't really look at. The extended abstract phase refers to a stage where sufficient knowledge on a subject has been acquired. This highly structured knowledge base can be viewed in other contexts or problems. So we now have very much a well-established schema. This is very well established. We understand this very well, how all the components fit together. But can we apply that to other cases? Well, the extended abstract phase permits the application of knowledge to other related scenarios and would provide a suitable structure for applied problem solving. And here we have one here. It's well established as a robust schema. It describes a particular case or set of cases. We can apply that to something which is unknown and come up with a robust clinical decision, a diagnosis. And this can inform on diagnostic reasoning for unknown cases with similar pathologies. And that's what extended abstract phase, that phase is all about. It's about, can we apply the knowledge we've learned to other situations? In summary, a learner's curriculum. Curricula are often, and we're all guilty of this, curriculum are often designed according to an administrative structure for use by instructors. What that means is, this particular lecturer will be teaching this on one day, and this particular lecturer will be teaching this in the afternoon on the same day. Well, it doesn't actually adhere to a curriculum which is structured for the learner. And a curriculum, we're in the education business, so the curriculum should be entirely designed and structured for the learner. Another important principle is to scaffold learning throughout the curriculum, to interlink all those learning points to see how they are linked together. And to make that explicit to the student, they have to know where they are in the curriculum. They'll not only know where they are, to know what comes next and what came before, and where they may be lacking in knowledge, but they'll also use that scaffold or use that curriculum as a scaffold for learning, so it will improve learning. And again, some evidence to show that. The most important aspect of such a curriculum is that these linkages of interrelated elements must be made explicit, so the learner must know them. It would also be useful to have sessions dedicated to scaffolding, which must really be incorporated into the curriculum and the schedule. We would schedule a part of a lecture or even a whole lecture looking at, or maybe not even a lecture, but if we're going to be really daring, something which is student-centered. We would look at establishing this scaffold so the student knows how this scaffold and they know how everything is linked together, and testing it would be ideal. Concept mapping should be continued throughout the curriculum in increasingly greater detail. Now we're getting down to the processing of proteins, of peptides, and molecular chaperones, what they're doing. Another thing we can do, well, how are we going to deal with it all? Well, a learner's curriculum needs computer-aided content scaffolding. We're in this age where everything is online, and we can really use that technology to establish something like this within a computer system, within a learning management system. And what would you do? Well, the curriculum firstly can be visually concept mapped. The learner will have access to the map on the computer system or the learning management system. They'll know how each element is linked together. They'll click on a particular node. It will take them to resources or other maps describing cell death, apoptosis, and activating a node on that map could easily be linked to content or other maps. And here we have one example of it being linked to content. So we clicked on the node for cell division, and it took us to this video describing cell division. That by itself isn't enough. It would be a series of learning resources and probably a map describing the process. Finally, assessment and deep learning. Assessment drives learning, of which there is no doubt, but also the type of assessment shapes the type of learning conducted. Now, assessment of fragmented knowledge or fragmented information requiring factual recall only drives surface learning. So we could have a beautifully mapped curriculum where we've gone through all of that effort, but if we only ask questions in assessment on factual recall, facts and figures, and not really asking questions on the interactions between systems or within systems, mechanisms, how they can be applied. If we're not asking those sorts of questions, we're only focusing on these factual recall, lower taxonomical level questions, then the student will only be driven to learn surface learning. So all of that effort in mapping and integrating the curriculum will be wasted. The assessment which comes from this type of curriculum has to be related to deeper learning, and it has to look at interactions within and between systems, mechanisms, and how they can be applied. Thank you very much indeed. And I